The pathology of type 2 diabetes involves two main issues. Firstly, insulin resistance. This occurs when the body cells such as muscle, fat, and liver cells respond poorly to insulin, which stores glucose in cells to use as fuel. Secondly, beta cell dysfunction occurs when the pancreas progressively fails to produce sufficient insulin to compensate for this resistance, causing chronic hyperglycemia, also known as high blood sugar. Driven by genetics and factors like obesity, this leads to excess liver glucose output, impaired muscle glucose uptake, and eventual beta cell exhaustion with inadequate insulin secretion. In simpler terms, the liver releases too much sugar into the blood, the muscles of the body absorb less sugar from this blood, and the insulin-making cells in the pancreas wear out over time, not producing sufficient insulin. I chose type 2 diabetes as the focus for my assessment because a close family member of mine has type 1 diabetes. I've seen firsthand its complex daily management and profound physical and emotional impacts, sparking my interest in understanding diabetes more broadly, including the similarities and differences of type 1 and 2 diabetes on the individual and societal levels. I also wanted to explore its effects on Australian communities and healthcare, where prevalence is high, and learn prevention strategies to reduce risk and support those affected. On the individual level, type 2 diabetes has impacts like reduced quality of life through physical limitations, mental health issues like depression and anxiety, and complications such as heart disease, stroke, kidney failure, and amputations. Nearly 50% of individuals face yearly mental health challenges worsened by self-management demands like monitoring, diet, exercise, and medications, according to Diabetes Australia 2024. Personal costs average $4,000 through $10,000 annually, doubling with complications and stigma from lifestyle misconceptions. Locally, in rural, remote, and multicultural communities such as Southwest Sydney and Northern Territory Aboriginal groups, type 2 diabetes prevalence exceeds national averages, with remote burdens twice that of urban levels. Vulnerable groups like Aboriginal and Torres Strait Islander peoples, who have up to 40% prevalence in Central Australia and Pacifica communities, suffer 5.2 times greater hospitalizations and 4.4 times higher death rates than average, straining services and requiring tailored interventions like church-based prevention. Limited access to educators, podiatrists, and specialists worsens complications, according to Diabetes Australia 2024. On a national level, Australia's healthcare system faces over $9 billion in annual direct and indirect type 2 diabetes costs, including $3.4 billion in healthcare expenditure, accounting for 10% of hospitalizations. This projects 3.6 million cases by 2050, according to the Safety and Quality Commission 2025. Burdens include 1.2 million hospital admissions yearly, GLP-1 agonist shortages, and poor preventative checks, which strains GPs, hospitals, and the Pharmaceutical Benefits Scheme, according to Diabetes Qualified 2025. Despite the National Diabetes Strategy, workforce, screening, and remission, gaps still remain. Globally, type 2 diabetes affects over 800 million adults with 14% prevalence, which has quadrupled since 1990. According to the World Health Organization 2024, disability-adjusted life years have risen 277% due to high BMI links and complications like cardiovascular disease. Low and middle-income countries bear 90% of untreated cases, mirroring Australia's rising youth onset trends and economic costs, for example, $413 billion in the US. Australia's experience aligns with this epidemic, emphasizing needs for prevention and equity in care. Primary prevention includes weight management through over 150 minutes of moderate physical activity weekly, for example brisk walking, and a nutrient-dense diet high in vegetables, whole grains, lean proteins, and low in processed foods, according to Medibank 2025. Prevention also includes smoking cessation, alcohol moderation, stress management, for example mindfulness, and blood pressure and cholesterol checks. Australian guidelines recommend AUSD risk screening, GP lifestyle referrals via the National Diabetes Strategy, and culturally tailored programs for high-risk groups. AUSD risk targets those over 45 who are overweight or from higher prevalent ethnic groups like Aboriginal and Torres Strait Islander peoples. Lifestyle interventions cut risks by up to 58%, according to Medibank 2025. A research question I would explore for type 2 diabetes in Australia is, how effective are culturally tailored, community-led digital lifestyle interventions in reducing incidence among high-risk rural and remote, Indigenous and multicultural groups versus standard GP-led programs? This targets gaps in national strategies like remote disparities, decline in research funding, and needs for precision prevention in diverse populations. It leverages declining incidence since 2010, focusing on youth and ethnic surges to assess scalable models amid workforce shortages.